as we speak. There we go. Okay. So if you go youtube.com/SciStarter, you will be able to find this recording very, very easily. I'm going to go ahead and link it in the chat for everybody, just so you have easy access. And if you want to communicate with us throughout, just use that Q&A box. We love hearing from you. So don't be shy. That being said, if you do use the Q&A box, we might shout you out by name. So we might say, oh my gosh, Andrew from, wherever you say you're from, Andrew from Milwaukee wants to know. And then we would ask the question. So be conversational, but if you ask a question, we are definitely going to shout you out, and that will end up in the recording. So that's just an FYI. So as you all come in, it looks like we got 19 people on so far, which is really exciting. Feel free to say hello to us. Use that Q&A to maybe tell us where you're from. Something you're excited about for tonight. If you already have a question, you could go ahead and throw that in there. We just want to hear from you and hear about what you're excited about. So don't be shy. Say hello. And oh yes, there's our closed captions, which is great. So yeah, we have auto-generated closed captions. So if you have a hearing impairment, I recommend using those. And also the recording will be available after the fact. I've gotten feedback before that I talk too fast. So if you need to go back and watch anything again, recording is there. No one's saying hello in the Q&A yet. So you might see some of the people behind the scenes. A lot of folks from All of Us Wisconsin are on the line, as well as our 3 panelists who are featuring tonight. And I'm looking to see if I see any familiar names in the audience, any friends from Wisconsin. None of them hopped on yet. Ooh, yay, the Q&A is getting active. Jolene says, hope you're having a great day. Thank you, Jolene, back at you. And then Jen says, hello from Central Wisconsin. Hello, Jen. Thanks for being here. And then we got Bonnie from Stevens Point, Wisconsin. Anybody on the line also from Stevens Point? No, Bonnie, I think you might be alone on that front, but we're excited that you're here representing Stevens Point tonight. And we also got some action in the chat, which is great. Jim is saying hello from Northern Wisconsin. We got Julie here from Wausau, Wisconsin. Lane here from rural Central Wisconsin. Great crew. Thanks for being here, everybody. And then we'll take one more shout out. Linda says hello from the Chippewa Valley. Okay, and Nicole also says hello formally from Central Wisconsin. Where are you, Nicole? Tell us where you are now. Very exciting. Okay, so I'm just going to share my screen to kick us off, and then we'll jump into our panel tonight. So let me just share my screen. As you can see, we are live on YouTube. And then, so first things first, I just wanted to give some quick framing. It is Citizen Science Month, all month long, all throughout April. You can go to citizensciencemonth.org to find real science anyone can do. Anybody can be part of the scientific enterprise, no matter your level of education, no matter how old you are, no matter where you are in the world, you can do real science and you can make a difference. And I can speak firsthand. I'm Caroline from SciStarter. I'm based out of Florida, but I've been to Wisconsin a lot. Thanks to our partnership with the All of Us Research Program and some other projects we support up in Wisconsin. And I've been really privileged to go around the world and work with people in all sorts of different communities who are doing real science. So what is this whole citizen science thing? Before we get to our speakers and our featured project tonight, which is the All of Us Research Program, I want to give a quick definition of citizen science. It goes by a few different names. Some people call it neighborhood science. Some people call it participatory science. Some people call it community science. At SciStarter, what we're mainly concerned with is that people are doing real science. So actually collecting and analyzing data. With data is just information for ongoing research projects. So data can be words and pictures. You can take pictures with your smartphone and submit those to researchers, and that's how they study different species. Our data can be analysis that you do. There's one project that I have listed in just a second called Stall Catchers. I just wanted to show these quick examples to show the diversity of citizen science before we get into tonight's featured project, the All of Us Research Program, which I'm really excited about. But there's also the Stall Catchers project that I do a lot, where you can classify videos of mouse brains for Alzheimer's researchers and help them learn new things about Alzheimer's disease. And there are also astronomy projects. One of my favorites, and I do it pretty frequently, at least once a month, is the Globe at Night project, where you can monitor light pollution in the night sky by just looking up at the sky and finding the featured constellation indicating how many stars you see. So citizen science is really diverse, and it's for all different fields of science. And at SciStarter, we are the world's biggest citizen science organization. So we have a searchable database of thousands of projects, events, and tools that anybody can use. And there are all sorts of different people who interact with us. We have a corporate volunteer program with Verizon. We have a Girl Scouts badge, but any member of the public can come to SciStarter and find a real project they can do. So I just wanted to throw this graphic up here to represent the diversity of citizen science and all the different parts and pieces of it. Okay, but what about our featured project tonight? The Office Research Program. So all the speakers we have here are going to tell you more about it, but I wanted to give some quick framing and also, let you know about this link that you can see on the screen, joinallofus.org/CSM24. I'm also going to go ahead and drop that in the chat just in case anyone is new to All of Us and wants to go ahead and sign up. So it's the All of Us is a project that is building the largest and most diverse health database of its kind. I'm actually an All of Us participant. I signed up. I'm very excited about it. And the big tagline is, you're one in a million. There have been over nearly 800,000 participants so far sharing their electronic health records. And this is, helping with the goal of focusing on the inclusion of historically underrepresented populations in biomedical research by showing up to places like libraries and, getting those communities involved. And researchers are already using this data, these surveys, these health records, the biosamples, like blood samples. I actually gave mine last week to learn about our biology, our lifestyle, and how environment all affect health. So it's making us all, and it's a real benefit for all sorts of folks. So if you're in the US, definitely participate. And the speakers online will tell you more about it. But basically the tagline is, the future of health begins with you. So go to that link I put in the chat. And if you're watching on YouTube, just type that link in. We have a special tracking link for Citizen Science Month so we can track our impact. joinallofus.org/CSM24 to help researchers make healthcare more precise. This event is possible thanks to the network of the National Library of Medicine All of Us Program Center. They have worked with SciStarter to empower public libraries, especially to build capacity with citizen science and to increase diversity and participation and to feature projects like All of Us. So I'm a big fan of the network of the National Library of Medicine. I wanted to tell you about all their free resources that we have involved and give them a huge thank you for making tonight's event possible. Also, as we said earlier, it's April Citizen Science Month. We're trying to get 1 million acts of science this month. So we want people to classify 1 million data points for citizen science projects. We want people to go to different events like this one. This event tonight is an act of science. And we want folks to participate in All of Us, because that's an act of science as well. And, all those things I just said count as acts of science. The main people are wondering, it's like, why 1 million? Well, we thought that would just get people excited. And that's the secret here. The whole thing about Citizen Science Month is you can do citizen science any day of the year. But in April, it's just our excuse to get a little extra excited and get people ready to do some real research. So that's my spiel. That was my intro. I am very excited now to hear from our speakers. We have 3 featured speakers tonight. And then after they introduce themselves and tell us a little bit about their why and speak to the theme of tonight's event, which is taking charge of health data, after they wrap that up, we'll be able to take your questions. And I also have some questions prepped too. We'll have a very lively discussion. So our first speaker is Aaron Perry. So Aaron, if you want to take the mic, the floor is yours.
Thank you so much for the invitation, Tyson and Carolyn, and everyone that decided to spend their evening with us. Thank you guys so much. But yes, I'm Aaron Perry, president, founder of Rebalance-Life Wellness Association based out of Madison, Wisconsin. And it's an organization that I kind of came up with the concept when I was a police officer and just doing the job, daily interaction. But there was a sense that I felt the job was really leaning and slanting more in favor of trying to arrest men or arrest people out of poverty. And I said that we cannot arrest our way out of poverty because poverty will win. I think we're seeing that now. And so made the decision to move on from the police department and, I joined the county gang unit for a little while, and now I'm doing my nonprofit full time. And I really enjoy making those connections and helping Black men improve the access or get access to better care. When I started doing this work, the average age of death for Black men in Dane County was 51 years of age. Just, kind of wrap your mind around that. A lot of people like to use the national average, which is 67. That wasn't the average for our county. And so that was really a driving force, because my first thought is, we have a top 10 university in our backyard. We have numerous practically billion-dollar hospitals and clinics in our backyard. We can collaborate together and figure this out. But that needle wasn't moving fast enough, and so we really got into a lot of the work that we're doing. But I want to make sure I get to some of the questions that, like, how can community organizations help individuals access health information? One of the things that I will share with everyone that's joining us tonight, you have to know who is in your community. I often have an opportunity to speak with our elected officials, and I love asking this question: do you know how many Black men and women are in the community? And I constantly hear, oh yeah, we got about 60,000 Black men, and I think it's about 70 or 80,000 Black women. And I said, no, actually it's 14,300 Black men and about 14,600 Black women. And so you got to know the community. You cannot help the community if you're not aware of actually who is living in the community. Those numbers are very important for me, because when we first started to do this work, and again, looking at the average age of death, we knew that we needed to reach a lot of men, and we needed to reach them fairly quickly. And so I had this idea of going into the barbershop and putting a health clinic there. And so I met with Madison's largest Black barbershop, JP Hair Design, and we sat down and had lunch, and I pitched it to him, and he saw it. He said this was a green light presentation. And so we moved forward, and I can honestly say I'm very proud of the fact that we opened the nation's very first health clinic inside a barbershop. Now, there's been health screenings that have happened, but we actually took it a step further and actually opened up a health clinic. And so we're really proud of that. The other thing that we did was we reached out to public health, and we asked them to commission a report with us, and it's the Social and Health Conditions Report for Black men. That was a very powerful report that we put together, because it talked about how many Black men are in our community, how many Black men have diplomas, what is the incarceration rate, how many men have served time and have been incarcerated. This is the importance of that report, because when you have that report, you can strategize and you can look at the different services that Black men need to have access to. And the most important thing, though, establishing trust. When we decided to go to the barbershop to open up our men's health center, I knew that coming into the barbershop was going to be a difficult task for me personally, because I was a former cop. And when I got to the shop, there were quite a few guys that they were pretty much determined that they were not going to talk to me. But I knew that it wasn't me personally. It was about that uniform, of the trauma of that uniform that I used to wear. And that's real. In spite of what people may want to believe, that trauma is real. And so I had to work through a lot of the sometimes disrespect, but I had to work through, again, that trauma of what these men, some of the men may have gone through. But I hung in there. It took me about 2.5 years before I actually felt like I had earned the trust of our community, particularly our Black men in the community. And so this is a message that I often share with my colleagues that are police officers that are in uniform, and that they talk about the community disrespects us all the time. And I say, hang in there, lead by example, stay true to your purpose. It will come, but you also have to be in the presence and be in the spaces where these men are at so that they can actually see you outside of the uniform. And so these are some of the things that I've been doing, and we've been very successful with this. We have provided preventative screenings for 7,400 Black men to date. And that's about 53% of the Black male population. And so we're really pleased with that. And we achieved that by partnering with Edgewood College. They bring over their nursing interns, and they do anywhere from an 8 to 12-week internship with us. They assist our physicians, they assist our AmeriCorps, and it's just a powerful engine that we built. And so I want to keep talking, but I want to be respectful of my colleagues' time.
Fantastic. Well, and we'll have lots of time for Q&A. And I know I already have questions about your journey and how you're helping people, empowering them with data about their own health. So thank you so much. That was very exciting, and I'm very excited for the Q&A. So up next, we have Dr. Kevin Izard. Dr. Izard, the floor is yours, and let me know when you want your slides queued up, but otherwise, take it away. And you're on mute.
Always happens. So my name is Kevin Izard, as Caroline said. I'm a family doctor in the Milwaukee area. I'm also the president of the Cream City Medical Society. Cream City, for those who don't know, is actually the Wisconsin group for the National Medical Association. The National Medical Association differs from the AMA, the American Medical Association, in that 125 years ago, when it was started, Black doctors could not be part of AMA. So the doctors at that time started their own organization, and it continues with the focus being on treating people who are in underserved areas, mostly urban. I'm the president of our local group in Milwaukee, Wisconsin. So let me talk about I'm going to talk about diabetes, but I'm actually going to change this up, and it's going to be a little different. So let me tell you disclose something about my own self. So in October of 2023, this past October, let's go back to October of 2022. I went for my annual exam, and I was pre-diabetic. Okay, what does that mean? That means that my blood sugar was higher than it should be, but it wasn't high enough to meet the criteria for diabetes. And so it was kind of a warning, say, okay, get your life in order. So I started doing some more exercise, and people in my office, we did a walk challenge where we did like a 5 mile every day. We had to do a 5 mile walk. And so I was doing okay. At least I thought I was doing okay. And then October of this year, of 2023, I started noticing that, because I started drinking more water, and I started noticing I was peeing more, but then I'm drinking more water. It's probably not surprising. And I was more thirsty. And then I said, well, you know what I should do? I should check my blood sugar, because I am pre-diabetic. So my wife has diabetes, so she has a glucometer. So I pulled her glucometer out. This is on Saturday. I check my blood sugar, and it reads high. Not a number, just high. And usually that means that you're over 500 if it reads high. And I said, no, that can't be right. I looked at I said, our strips are expired. It must be expired strips. So I said, let me check. I'm going to go in the office tomorrow and check it. So after church on Sunday, I went to the office and checked it on our office glucometer. And so I fasted from that point on. So when I checked that blood sugar in my office, it was 375, 376. And I was fasting. And I said, oh my God, I'm diabetic. I didn't want to be diabetic because I know enough about diabetes and know the consequences of it. We know that diabetes increases your risk for heart disease. That's the main thing. It increases your risk for kidney disease. It increases your risk for amputations. It increases your risk for stroke. It increases your risk for blindness, retinopathy. So I didn't want to deal with all these things. Plus, it's expensive disease because insulin, at least now the prices come down. Congress has done something about that, but it's expensive. My father-in-law had diabetes, and I remember before he passed, we'd be at dinner, and he'd want a piece of cake, and I said, "Willie James, you can't have cake. You're diabetic." And he said, "No, you can't tell me what I'm going to eat. I'm a grown man." I didn't want to do all that stuff. So I said in my mind, okay. Well, first of all, this is Sunday. I'm sorry. So Monday morning, I came in. I had my MA. I talked to my doctor. I had my MA draw a test called a hemoglobin A1C. Okay. Now, that's an important test you need to know if you're diabetic. Hemoglobin A1C. Can you put that second slide up with the? I don't think I have. I take it back. I don't have hemoglobin A1C up there. Hemoglobin A1C is, let's leave that one up there. Yeah, that's a good one. Yeah, leave that up there. So hemoglobin A1C is a test that looks at your blood sugar. Now, there's actually 4 different ways we diagnose diabetes. One would be if you have a random blood sugar over 200. You should be able to eat an entire cheesecake and your blood sugar shouldn't go over 200, okay, if you're normal. So anytime someone has a blood sugar over 200, that's diabetes. The second way would be to do a fasting blood sugar. And some of you might have had that. So you go to the doctor, you fast for 8 to 12 hours, you check your blood sugar. It should be ideally should be under 100, but the criteria for diabetes is if it's under 126, okay? It was over 126 on 2 separate occasions fasting, that's diabetes. The third way would be to do what's called a glucose tolerance test, where you have your fast. We give you this fixed amount of glucose to drink, and then we see your blood sugar go up. So after 2 hours afterwards, your blood sugar shouldn't go over 140. If you're pregnant, it shouldn't go over 160. But sometimes if you've ever been a pregnant woman, you might have had a glucose tolerance test. And then the last way would be this test. I talked about this hemoglobin A1C. Now, the advantage of the hemoglobin A1C over these other tests, especially like over the fasting glucose, is that your glucose, when we do that test, usually in the morning, is going to depend on a lot of things. It's going to depend on when you last ate and what you last ate, how active you were, and what time of day it was. And so the hemoglobin A1C looks at the effect that the blood sugar has on your hemoglobin. Not that it does anything adverse to the hemoglobin, but it's a good measure because there's a direct correlation between your average blood sugar and your hemoglobin A1C. So a normal person's hemoglobin A1C will be 5.6 and below. If it's above 5.6, that's abnormal. However, the criteria for diabetes is above 6.5. So if you're in that, and this is where I was the year before, I was in that range between the 5.6 or 5.7 and the 6.5, which we call pre-diabetes, meaning that you're increased risk for developing diabetes in the future. So I was in that yellow light area. So when I got my A1C on Monday, I was shocked because the results came back and it was 11.6, which is extremely high. Meaning my blood sugars were averaging probably around 270 something. Normally blood sugars will be like averaging around 100, between 100 and 125. So I was panicked. I said I don't want to be diabetic. So I made my mind. I said, by next time we check a hemoglobin A1C, so we check it every 3 months because it takes that long for it to change. And that's the advantage of it. It doesn't change. So if you go into the doctor, I have people who are diabetic, they come in for the A1C and they know that they haven't been taking care of the diabetes, so they fast and they're extra good for the couple of days before. You can't do this. You can't cheat with this test. It's going to look at your blood sugar average over 2 or 3 months. So I kind of set in my mind, I said, when I check this again in 3 months, my goal is to be out of diabetic range. I want to be below 5.6. I said below 6.5. And so first thing I did was I cut out all the sweets, and it wasn't as hard as I thought. I started doing low carb, not the really strict low carb. I mean, I just basically no potatoes, no rice, pasta, or at least I did very small amounts. I started exercising. I actually started losing weight before I found out I was diabetic. And that was part of the symptom. That's one of the symptoms that happens is that you start peeing a lot, and guess what? You're peeing out sugar, and sugar has calories. So you're actually peeing out a bunch of calories. And so, so I continued to start losing weight. Um, and this is where we come to citizen science. So I got this thing, and you guys can see this on my arm here, but that's we'll call it a continuous glucose monitor. This is a Freestyle Libre, and I have become a huge fan of this thing because usually what I've done when I've had diabetic patients, let's say, people who are newly diabetic, we talk about the diet changes and do this. And we say, okay, cut all the sugary drinks out and cut the snacks out and try to lose weight and exercise. And we'll see you in 3 months and see what it looks like. The problem that is it's hard to connect what you're eating for dinner today with what your hemoglobin A1C looks like 3 months from now. This thing allows you to, in real time, see your blood sugar. And actually, and what I've been telling people, my new patients, I said, get this thing. Now, one of the things that, and this is where you can really do this as a citizen scientist or amateur scientist, is that you can get one of these things. If you're pre-diabetic, okay, meaning that you're probably overweight, you're not diabetic, you don't need to actually get a glucometer, but you can actually get one of these things for free. Talk to your doctor; they will give you a free monitor for it works for 2 weeks, okay, and it works on your phone, your smartphone, and you can see what your blood sugar is running. You can make some changes to your diet. You can try eating different foods. What do potatoes do to your blood sugar? What's going on my sugar in the morning when I get up? How does my sugar vary through the time of day? You can see all these things, and so it's a great way to kind of experiment and to kind of see because not everything works the same on me as it does on someone else. So basically, I did a full court press, and this is what your kind of readout kind of looks like this. Okay, I don't know if you guys can see that, but you get a little graph there, and you can see what your sugar is doing. And this thing has really been great. So I got my follow-up A1C at the end of February, and I was down to 6.4. So I hit my goal. I was out of the diabetic range. My next goal was that I don't want to be diabetic in a year. So I'm weaning up myself off medication, and we can talk more about that. But for those who are diabetic, I want to challenge you, because the standard of care so far has been to manage diabetes. So we'll give you medications, and it'll raise your insulin level to bring your sugars down. The problem, though, is that insulin is part of the problem. And so people have to really look at not just taking more medication or especially taking more insulin, but think about ways of doing intermittent fasting or doing low carb diets. Both of those can actually get you out of diabetes. They call it being in remission, not necessarily curing it, but put yourself in remission, and because for your overall metabolic health is going to be better for you. So I'm going to yield it back to Carolyn, and we can talk more about this in the conversations.
Exciting. Yeah. And it was great to hear about your personal story and how you took charge of your health data. And I'll have lots more questions in the Q&A, especially about how all of us can potentially interface with that as well. So thank you so much, Dr. Izard, for sharing. Mm-hmm. And then we have our last but not least speaker, Dr. Casper Bendixsen. So the mic is yours.
Good evening, everybody. Casper Bendixsen, everyone just calls me Cap. Really glad to be here tonight, and it's part of the All of Us programming. I've had a couple opportunities to speak to different audiences on behalf of the program, and I think on the topic of taking control of your health data, taking control of your health, I'm just really privileged to be able to say something about that. Thanks to my other speakers as well. Great stories. I think the idea is of taking control of your own data and health, and then building trust in a community really speak to me. I direct the National Farm Medicine Center. So the National Farm Medicine Center is a research center within the Marshfield Clinic Research Institute dedicated to agricultural health and safety. We're the largest full-time center in North America, probably the world, and one of the longest standing centers who focus on the health, well-being of farmers, farm workers, and the families of those people. Why do we do this? Farmers and farm workers and farm kids get injured, and they get fatally injured often. They also are predispositioned to long-term illnesses related to cancers, respiratory illnesses, so on and so forth. So a lot of epidemiological reasons why. I will say that one of the big things that we focus on is the fatalities. If you work in ag, you're anywhere from 4 to 6 times more likely to die on the job than other people at their job. And if you are in any sort of ethnic or racial minority and a farmer, that number just goes up. And so when we look across the United States landscape, we want to make agriculture a different environment. We want to make it a healthier, more well-promoting type environment. And there are aspects to ag, such as being your own boss, being mission-driven, feeding people, raising animals, being outdoors, that all work at people's advantage in their health. In fact, we know that kids that are in utero or grow up near livestock really less likely to have asthma, allergy, and atypy. So there are positive elements in that environment. But in particular, when we talk about taking control of health data, we know that if a physician and their nurse and their MA and the teams around them understand where you're coming from, they can do a better job of taking care of you. So if they have a sense of what you do for a living, if they have a sense of the risks that are in your everyday life, they can start to be more precise, use precision in their diagnosis and in their treatment. And so on the topic of health data, I'm very proud to be a part of an infrastructure that takes the social determinants of health seriously. And so for our patients in this environment, we do ask the question of everybody, what is your occupation? What occupational sector do you work in? Because we know that if you're a painter, we can talk about respiratory. If you work outdoors, we can talk about skin cancer. If you work in a high fatality or high injury, we can talk about safety. And so these are the elements by knowing what you do for a living or what environment you're coming from. Sharing that information with your healthcare team will make a difference. We're doing it a little bit more deliberately in the demographics of our EHR. And so I would encourage everyone on this call, everyone on this meeting, when you are asked to consider sharing your data with your healthcare system, think deliberately, think conservatively about, because you are sharing that data, but then think about what could be done with it. Think about being involved with being a part of a cumulative amount of data, which is what all of us is all about. But that cumulative amount of data is what makes a difference. It's what tells us that if you are male, over 50, in a rural environment, we know that disposition is going to be higher for different forms of respiratory disease, cancers, and diabetes, all topics that we've talked about today. And so part of my pitch here this evening is to share that. Another good example of data that we're being much more deliberate about collecting these days is veteran status. So if you have military experience, you've been deployed and activated, we know that depending on where you were and what exposures you had, there's questions we need to ask you as a healthcare team. And so engage in that conversation. Don't be afraid of that conversation with your healthcare teams and do that. On the level of trust, which I think is paramount, the All of Us program is more than just sharing genetic material with a collective whole. It's about representing your community as a part of that sample, but also the survey questions you asked. Just 5 minutes before we got on this call, I got a phone call from the All of Us program reminding me that I've got new surveys to fill out. So I'm in All of Us to fill out the surveys. And one of those surveys that's really helpful for my line of work is the environmental and the occupational survey. We do ask all of us participants about, the work environment that you work in. And that's going to vary across the country. On the level of building trust, we were very fortunate just 2 weeks ago. We were doing safety training on a Navajo Dene farm down in the Four Corners area. And so what I will say is that if you build programs and participate in programs, you can see something grow in front of you. what began as 20 dairy farmers telling us, answering the question, who would you trust with safety advice, has led to a program that's been in 11 states and 5 Canadian provinces. So I'm entirely indebted to 20, central Wisconsin dairy farms who said, I will participate in research because I think the outcome will benefit me and my neighbors and the people I don't know who are also in my profession. And so that would be my other pitch is as a part of being a citizen scientist, think about the research studies that you can be a participant with and be curious. Ask the research team questions. Ask for your data back so that you can make sense of it. Take control of those things and really enjoy what part of the community you end up representing, because regardless if it's an urban environment or a rural environment, tribal, non-tribal, whatever, you come representing a community, and that will impact the future generation of health of the communities that are like that coming out. So I'll stop there. I yield my time back to the conversation that I hope we have.
Fantastic. Well, so we have heard from our speakers, and for those watching, you can go ahead and get some more questions in if you have initial questions that you want the speakers to know. Oh, it looks like Annie said, Dr. Izard, I grew up on 15th and Concordia. Izard's Grocery, any relations? And he said, was a cousin's grocery store. So I love it when we realize that the world is very small. That's very exciting. Okay, so I have an initial question off the top, and I think Dr. Bendixsen started answering that. So we're here tonight in part because the All of Us Research Program is a featured project for Citizen Science Month. And I think all three of you spoke really movingly about health data, your personal journeys, the work that you do. Would any of you like to expand about how the All of Us Research Program empowers the work you do or intersects with it? Maybe Dr. Izard, do you want to take that first?
Yeah. As Cap had alluded to, when you get that data back, that's powerful stuff. It not only is it kind of individualized a look at your genome, but also you can find your ethnic history, and there's a certain amount of interesting information there, and so I encourage people to take control of your, like, for instance, if you learn that I got this certain gene, and so maybe statin medications don't work as well for me, or maybe I'm more likely to have a side effect from it. That's something that's that you can share now, with your doctor that they probably didn't know before, because we don't screen for those things, and so it's important that you be really the steward of your own health and take charge of it. And so a lot of these things as you learn more about different things, share it with your doctor. I know we hate hearing people reading things on the internet, but it's always a good conversation, so bring it to your doctor and say, oh, I read this. Is this true? What do you think about this? And, they might not agree with you, but still it's a good conversation starter. So, I definitely would encourage people to really, get that information, for yourself.
Yeah, and if I could add, I actually participate in All of Us as well. I participate for a specific reason, and Dr. Izard, I've been diabetic for I'm 60 now. I've been diabetic since I've been 29, and I've seen the ups and the downs of diabetes. I've been diabetic for quite a while. I've had some success though with diabetes. I'm the world's first African-American diabetic to do an Ironman triathlon. So yeah, I encourage people to Google that. People always say, really? Just Google it. But I joined the All of Us research program because when I was diagnosed with diabetes, I was doing everything that my doctor advised me to do. And I finally came back and I said, Doc, either the research is off, something's missing, because I am following your protocol. I'm exercising, I'm eating right, I'm doing everything. So we decided to do, a lab workup again. And so in doing that, they realized my blood sugars, or my A1C, was too high to be type 1 and too low to be type 2. So I'm actually type 1.5. And Google that it is such thing as type 1.5. So once we found that out, I said, okay, now I got some answers. I said, so let me have that type 1.5 regimen. He said, there is no type 1.5 regimen. So you're either going to have to be on a type 1 regimen or a type 2. And so I tend to navigate through both of type 1 and type 2 regimens. And so I joined the All of Us because I need to have a type 1.5 regimen, because if type 2 doesn't fit me and type 1 doesn't fit me, you're just throwing me in the category. I'm really not comfortable with that, but again, I've had some success, with diabetes, and I'm now, same as you, Dr. Izard, I'm really looking to try to get off all medications. And so that is actually my goal this year. I was blessed to do a talk at the Boston Run Show. And while I was out there, I did a presentation and I talked about diabetes. And I guess I caught the attention of the person who runs the Boston Athletic Association. And so they gave me a complimentary entry into the Boston Marathon of 2025. And so I'm starting to get prepared for that, but I'm still noticing that, I'm really struggling with, getting this tight control. And I don't know if it's because of the type 1.5. So I'm focused a little more on the type 1 regimen now.
Thank you for sharing that. And that's great that All of Us has been a good resource for you and, your own unique personal journey. And also congratulations on the Ironman. I'm seeing some questions come through in the chat. I think people just want more info about diabetes in general. Where can I get this continuous glucose monitor? Medicare won't cover it. What's a good carb? What's a bad carb? I know we can't cover everything about diabetes in this program, but maybe Dr. Izard, if people want know more about diabetes, where should they go?
I would, there are a ton of different websites, so kind of be cautious with that. Anyone can make a website. Try to use reputable places, Mayo Clinic, anything with the CDC, the American, ADA, those places are, very reputable places. But there are also, and again, this is going to science, there are people that, like I've been seeing a lot of people talking about apple cider vinegar, kind of lowering your blood sugar and kind of reducing the spike that you get after eating carbohydrates. Now, it looks like some of the studies that are coming out are kind of supporting that. Maybe there is an effect that, that apple cider vinegar has. But of course, that started off with people just doing it and doing their own experiment, and and then it bleeds over into the traditional science. And so sometimes when I talk to patients about this whole thing with metabolic syndrome, I don't know if people have heard about metabolic syndrome, but this is whole syndrome that includes diabetes, but high blood pressure and high cholesterol and obesity, and they all work together. And the thing they pretty have much have in common is that, you have this high insulin state and your body is resistant to insulin. So it makes more insulin, and that insulin makes you gain weight, and it kind of causes this big spiral, and you get cholesterol because of all the fat that builds up in your arteries, and you're more susceptible to heart attacks and strokes. Well, this whole thing with metabolic syndrome is we don't know exactly, what causes, why some people have it and some people don't. Why some people are, I got, a couple of patients who are over 300 pounds and you swear they're diabetic and they're not. And other people, they're thin and they're running marathons and their blood sugars are still high. And, or people come in and they swear to you, Doc, I'm eating, I'm just having soup and water, and that's all I'm taking, and I'm still gaining weight or nothing's coming off. Okay. And so this is where, your genes actually help us, because, when we do these, when we look at the data in all of us, we can go back and we can see, okay, these are diabetics, these are some of the characteristics they have. People who are able to who respond well to low carb diets have these genes, and people who don't maybe have these genes, or they have a different condition, or we think everybody is type 1 or type 2, and we find, oh, well, there's a 1.5. But that only comes about by studies. That only we can do the studies if people, consent to letting us examine them and use their data.
Definitely. And that's really interesting to hear that, some lifestyles can be so different and people can have such different outcomes based on all sorts of different factors. So maybe Dr. Bendixsen, you could speak to that, maybe the value of precision medicine for conditions like diabetes based on your work.
Yeah, I mean, so there's two phrases floating out there. One of is a little bit more popular than the other, and that's precision medicine. And this goes back to this previous suggestion of like being flagged in the EHR, for being on a certain diagnosis and then a prescription that'll be more or less effective, right? So that idea of if we have that genetic information alongside of good diagnostics from a physician, the combination means you get a better prescription, you get a better dosage. And so the idea of being precise with our prescriptions, and it's not just going to be, in pharmacology, it's not just going to be the drugs we take, it's going to be the regimens that get recommended. So the idea of losing weight with bad knees, that's going to be a different conversation. The other phrase that I do enjoy quite a bit, because I do like being on the prevention side of illness and injury, is precision public health, meaning that where we can be precise about a medication, we can also be fairly precise on this community here needs this more than this. And so when we look at, for example, respiratory illness in the farm community, we know that early in life, that exposure means we have less respiratory disease. But there's some breaking point at which if you stay in agriculture your entire life and remain exposed to feedstuff, manures, grains, molds, whatever you have on the farm, you're going to develop a long-term adult respiratory illness, unless you either modify your environment so that you have better air circulation. So this is building design, things like this, or respirator, right? So PPE. And that's not just that my example is agriculture, but if you look at the amount of urban and rural communities that are now adversely affected by wildfire smoke, that all of a sudden becomes very real for everybody. And I think Wisconsin kind of had a reality check this last summer when we were getting the Ontario smoke. And so by knowing you're in a community where you're a predisposition to have a respiratory illness because either highly rural environment because of the agriculture, or urban environment because of diesel fumes and different fumes within those urban environments, that wildfire smoke is going to affect you differently. And so that's where this idea of precision public health can be deployed if people participate with sharing who they are and their dispositions.
Yeah, I think it's fascinating. I remember during COVID, that was the whole idea about like who had respirators and where they went, or who had ventilators, just to say, and what communities had them. And doing precision, if you use precision, we could move the ventilators to the places where the spikes were happening instead of everybody having their own. So yeah, I really think that idea of getting more precise with what we're doing, what resources we have for specific communities, and what things that community is more prone to, and I think we'll spend our healthcare dollars better in the long run.
Yeah, and because there is no cure for diabetes right now, I for me, and I always recommend this for guys that come into the barbershop and we know that they get diagnosed with diabetes, but have it with your medical team. Your medical team will keep you alive. Your endocrinologist, your diabetes educator, your nutritionist, and you can benefit from reaching out to those sports physiologists as well. Your insurance should cover that. But these are the people that they're the experts. And until there is a cure, I have to put my trust in them. and there's nowhere else to turn. And so I would just really encourage people to really stay, focus on the latest research. Obviously, I have the Dexcom G6 sensor. Again, as Dr. just said, that's a lifesaver. I just tested, and I'm 131, so I'm doing okay, but this has been, 31 years of learning this as
Mhm.
well. But definitely develop a relationship with get your medical team together. And then when you're in the neighborhood, and if you don't have a running club or a walking club in your neighborhood, create one, and make sure you're taking those after meal walks. That's very helpful. These are the things that have been successful for me.
Yeah. And, for those, I see some questions about like how do you get the glucometer? The, some some insurances will not pay for it if you're not on insulin. Okay, some won't pay for it if you're not diabetic. But the thing of that I was suggesting you could do is if you go to Abbott, who's the manufacturer for at least for the Freestyle Libre, and I can't remember who makes the Dexcom. Both of them will give you a free sensor. So basically, you go in, you fill the information out, and your doctor can write a prescription. It goes to the pharmacy. There's no charge for it. If you pay out of pocket, it's $127 for a month for two sensors. So if you decide you want to pay that, you can do it. But at least get the free one. Try it out for 2 weeks. Do 1 week eating the way you normally eat. The other week, try to make some changes and see what it does. But at least you can get that 2 weeks, and then if you could do the free one through Freestyle Libre, and then get the Dexcom one, and you got another 10 days of that one. And so, between those two, you got almost a month where you can kind of play around with it and see what you get. It doesn't cost you anything. So it doesn't run through insurance. Okay. So all you got to do is you got to talk to your provider and get a prescription for it, but it'll be covered in that way.
Yeah. And one of the resources I would like to share, if people don't have insurance, look up, and Tyson just put that in the chat, but Wisconsin Association for Free and Charitable Clinics. We actually opened up a free clinic here in Madison. We have a primary care clinic, the Perry Family Free Clinic, and we also opened up a free dental clinic. But we're starting to see a significant outreach from kind of our immigrant population. And so we're really rolling up our sleeves, and I've been very active in getting, we now had to do business with the language line because we have folks coming in and they speak Woolly. I love my staff when they say, I learned Woolly today, but it's a lot of things that people can do. You just got to know the resources. But I would definitely start, you should not have to go with having, not having diabetes, or having diabetes and not having the resources. Check into those free clinics. They can put you on the path.
Mm-hmm. Yeah.
So,
and thank God now that there's legislation now to bring the cost of insulin down, because that was a huge one for a lot of people. So really use those resources so if you can get your insulin cheaper, or even get off of insulin, even better yet. But yeah.
So we're getting close to the end of the event, and let's say I'm an attendee. I was here, I got inspired. I'm ready to take charge of my health data. I've never really tried this before. Maybe I'm new to the whole world of health. What do you all recommend that I do? Whoever wants to take this one first. If I want to take charge of my health data, what should I do after this event?
I would say, first of all, if you haven't had an annual exam, do that. Meet with your provider, your nurse practitioner, your physician, and say, these are my concerns. This is my general health, what it's been, and then what test do you recommend? Okay. And some of the, again, people do different tests. Sometimes people do unnecessary tests. So we try to make them evidence-based. But, you should, if you're overweight, meaning that your body mass index is over 25, which 2/3 of Americans are either over 25 or obese, which is over 30. Or if you got a waist circumference for a woman greater than 38, for a man greater than 40, you should really have a hemoglobin A1C test done. And it'll let you know if you're pre-diabetic or if you're diabetic. If you're pre-diabetic, you're not diabetic yet, but at least boy, I need to make some changes, because if I don't, I'm prone to becoming diabetic, in the future. So yeah, you should get that done. Maybe fasting blood sugar. And of course, we didn't talk about things like blood pressure. Definitely, you need to be aware of what your blood pressure is. Those things also, cholesterol, those things are also going to predispose you to a heart attack and stroke. But yeah, definitely talk to your provider, and I will start off there and get some basic tests and an exam.
Yeah, and I was just out at a conference last week, and got Mark Cuban was there, and he talked extensively about his Mark Cuban Cost Plus
Mm.
drug company. I would highly encourage folks to look at that. This guy, is a billionaire, and he's decided that even
Mm.
he was looking at the cost of drugs and saying we can do better, and so he decided to create a company. And one of the drugs that he talked about specifically, he said it was $27,000. He now offers the
Mm.
drug for $67 a month, and so I would encourage, I'm hope it's okay to give out these resources, but Mark Cuban Cost Plus drugs, I would definitely look into that.
Yeah. I definitely got a thumbs up, and between him and Walmart's another one that's really doing a lot to bring costs down, for things that are otherwise expensive. And it's a shame that that the insurance industry in itself isn't doing it, but sometimes it takes people on the outside to make those drive those changes.
And Dr. Bendixsen, what about you? If I want to take charge of my health data, what advice do you have for me?
Well, I'm going to repeat Dr. Izard's comment about getting that preventative visit in. One of my main concerns, actually, post-pandemic is less about as infectious disease as it is how complacent people have become with not going to see their doctor. So, we went through these 2 years where we said, don't go to crowded places, don't go to the medical facilities unless you absolutely have to. And so I very much worry that people have become complacent with the idea, well, I haven't had my annual physical and I feel fine. And so that annual physical is really important. And it makes me worried actually about late diagnosis. So that could be diabetes. That could be you've given up your chance for being caught pre-diabetic. And now you're diabetic and you've got a steeper hill to climb. It also could mean that you're going to be fighting a stage 3 cancer instead of a stage 1. And so people have become complacent without those annual visits. And really, they need to be emboldened to ask hard questions of their physicians. For a long time, in this country, we went to the physician, we got told what was wrong with us. They gave us a pill that we didn't understand. We took it. It doesn't work that way anymore. It doesn't have to work that way anymore. We're allowed to go in there and talk to that physician as a colleague, as a person that is supposed to be on a team with other people, us. And so I would say that visit by itself, and then sharing what you feel, even if it's just an instinct, a very slight rumble in your tummy that maybe I should tell them what I did for 20 years before I became an accountant, right? And then it turns out that you were, doing something that might affect your health. And then the other thing too is look at the citizen science opportunities. Look at the things that are coming out of organizations like yours and all of us. And you're going to learn something. You're going to learn something new about your neighborhood. You're going to learn something new about you and your family. And knowledge is power. So, I mean, that idea of getting to know the world around you through data, through science. And lastly, look for those organizations that are designed for you. Look for the organization where you can see yourself being a part of it. Even if it's, a group about poverty. They're probably going to talk about disease in that group. They just happen to have an identity that revolves around a different social issue. So that's the other thing is I would get involved with those communities that look like you, feel like you, and maybe answer some of the questions that you've been having and haven't had a chance to ask.
Yeah, we're almost at the end of the event, so I'm going to leave the survey up, but I want to give everyone a chance to offer some parting words of wisdom in our last few minutes here. So maybe Aaron, we can start with you. What closing message do you want to share with everybody before we go?
Yeah, I would say the All of Us program has great promise, but we still have to give our bodies a fighting chance to survive until this promise occurs. And so we have to do our due diligence to take care of our health, to take care of ourselves, get our screenings, Spend some time on my chart, interacting with your doctor. But these are the things that I would recommend.
Fantastic. Dr. Izard, do you have any parting words of wisdom for us?
Yeah, I would say, you are the steward of your body. You are the head of your healthcare team. And Cal was kind of alluding to this. When you go in to see the doctor, they're working for you. As a physician, I can tell you, if you don't push for that, it's easier for me to tell you what to do so I can move on to the next room than to have to explain to you why I'm doing what my rationale is, or to listen to you and to listen to maybe your alternative for what you might want to do. But push for that, because, again, you are the one that's going to live with the consequences of that. And so, really take charge, and don't be afraid to ask questions. Write them down if you need to when you go into the doctor.
And Dr. Bendixsen, any final words of wisdom?
Yeah, I think the idea of taking charge of your health data for yourself is paramount today. I think we've discovered that through the powerful stories of my co-presenters and the groups that they've worked with. But then also keep in mind that you probably have many of the same issues as somebody else. And that includes the people you're directly related to. So when you start participating with research, when you start taking charge of your data, you're also contributing to the community sense of what needs to be done first. It helps build us that idea of precision public health. It helps us give us priorities, and it's probably gonna help someone directly in your sphere, whether that's friends and family. And so by taking control of your data, by participating with science and with medicine, you're gonna help somebody else too. So even if you think you're in pristine condition, go in and do it.
Fantastic. It looks like we have 1 minute left, so I think we can answer that last question in the Q&A. Anonymous attendee wants to know, what are some basic tests a person should have at the annual physical?
Probably depending on your age. Well, a lot of it depends on your age and your gender. So a woman's not going to get a PSA. Maybe a prostate specific antigen. But if you're a male, let's say a male over 50, you should have colonoscopy. Actually, both people, men and women, colonoscopy. If you're over 45, you should get a PSA, which is a prostate cancer screening test. If you're a man over 50 or 45, if you're high risk, you should have your cholesterol done, and total, or if it's abnormal, or if you're at high risk, you should have that broken down into the entire lipid panel. You should get a hemoglobin A1C if you're overweight, or if you have a strong family history of heart disease. And those are the ones that there's really a lot of evidence behind. Women also pap smears, and mammogram. And there's some controversy about when that should start, 40, 45. Some of it depends, again, on family history. If you're a smoker, there's evidence that supports getting a low density CAT scan to screen for lung cancer. Chest x-rays aren't good enough for that. But that's it for people who have a 25-year pack. If they smoke for 25 or more years worth of cigarettes. So those are the basic kind of screening tests that we do for people.
Fantastic. And I think one thing I heard from today's event is just communication. So people should just share their demographics with their doctor as well. And I'm sure their doctor will be able to set them up with all sorts of tests that are relevant for them.
Yeah. And you know what? And people don't realize this. The most important thing that I do when I see a patient is not the exam. The exam is the least important thing. The most important thing is the history. So if something's going on that's significant, you're going to tell me. You're going to tell me, oh, I've been having hot flashes, or I can't sleep, or I've been gaining weight, I don't know why, or I've been peeing a lot. Those are all things that kind of trigger something in my mind. Is, oh, okay, we need to really screen for this, and we need to screen for that. And so if you don't tell people that, they don't know to check for it. So, again, try to be very specific as far as what's going on with you.
Fantastic. So I think we are out of time. So I'm just going to go back and remind you all that the All of Us research program is here for you. So go joinallofus.org/CSM24 to get involved with All of Us. That's a great step in terms of taking charge of your health data and also helping everybody else make medicine more inclusive and more precise for all people. And then as a reminder, it is Citizen Science Month and the 1 Million Acts of Science. So I'm just going to keep going forward. Here you go. So make sure you take our survey on tonight's event. And if you go to citizensciencemonth.org, you'll find many more events. And also, if you tweet or post on Instagram or, wherever your social media network of choice using that hashtag, you will not only make my boss's day, but we will also be able to celebrate you for this global effort. So I'm going to stop sharing here and say farewell. And thank you to all of our panelists and organizers today. Have a good night, everybody. Woo! Everybody enjoyed, got some informative, some claps.